also complementary. And in reality, in the patient with the CABG, with the first revascularization bypass surgery, after 5 years, need to subsequent PCI 11.7%. And in the group with the first revascularization PCI, after 5 years, need for subsequent bypass surgery 7%. And they do extrapolation from the data from German 2015. They give estimation within 5 years, 6,000 PCI post the bypass surgery and 3,000 bypass surgery after intervention. And according to the European author, they give how we can choose the strategy for repeat revascularization of score. We met it on the basis of the heart team, and some factor can give more look like according to guidelines, such as the European guideline or American guideline, patient preference, resource, and operator skill is very important. Sometimes we have a very good choice, but we cannot do. And some factor of the anatomy can help us to choose med decision, such as if an anatomical complexity of coronary artery disease, it go to the bypass surgery, it less anatomy, it's suitable for intervention. If the heart failure, it approved for bypass surgery, preserve the ejection fraction, approved for intervention, or diabetes, or few comorbid condition and high morbid condition, approved for the intervention. And low SDS score risk, high SDS score, and non-emergency clinical emergency. So it's the some factor can help the interventional cardiologist can make the decision which strategy we will do for repeat revascularization. And this is the recommendation of the ESC guideline. If the patient after bypass surgery, the CABG is reduced, but sometimes the intervention is a good choice, particularly as you see, PCI for the bypass native artery should be considered over PCI of the bypass route. It means if we do repeat revascularization in the patient with reverse bypass surgery, better we do to the native coronary artery. And DES and for the treatment of instant restenosis of stent, DES are recommended. And this is look like you have your discussion, DCP. According to the guideline of ESC guideline, DCP is still a class 1A. The difference between two sides of Atlantic Ocean. And if the patient have many recurrent episodes of diffuse instant restenosis, bypass surgery should be considered. However, in our reality, particularly in Vietnam, and look like some similar to the many countries, PCI is almost the only option because patient refusion of bypass surgery, or maybe high-risk patient for surgery, or need to revascularization after bypass surgery, and cardiac surgeon do not like to do repeat revascularization, in particularly a triple vessel disease with full metal jacket, nowhere to insert a bypass graft. And the diagnostic tool of score look like it is similar to the presentation of Dr. Michael Lee. Intravascular imaging always be recommended to assess the neo-intimal hyperplasia, OCD, and IVUS, to assess the neoatherosclerosis, to assess the late acquired malposition, to assess underexpansion. It's very important for us to determine which strategy to do, or to assess evagination, to assess stent thrust, to assess S dissection, so on. So according to the guideline of ESC guideline, IVUS and or OCT should be considered to detect a stent-related mechanism. So we can match how with the strategy of revascularization according to corollary anatomy, medical comorbid, experience, or our skill, and particularly based on preference. And I have some case for demonstration. The first, I would like to present one case with post-bypass surgery to repeat revascularization. The first is you can see 5 years ago, 5 years ago. This means the patient were bypass surgery in 2013, and after 5 years after coronary angiogram, you can see a small diffuse lesion in the right coronary artery, and diffuse lesion all of the left coronary artery, particularly distal left main involved to the pole ostium of LAD and circumflex. And upscore cardiac surgeon then like to do repeat bypass surgery because the first the scare, lima, and a very small vessel where we can position, we can insert the bypass graft. So after do explanation and with the preference of the patient, we made the decision to do PCI for repeat revascularization. And the lima, as you see, the patient have one patent graft from vein graft. So according to guideline of ESC guideline, we made decision to do a PCI to native coronary artery. And before we perform PCI, we think may be very difficult, but when we do the PCI, I think not very difficult for us, for all mode of us. You see, for the right. And in that time, we don't have the intravascular image, so we cannot recording the image intercoronary, and the left more a little bit more difficult. Get better, and we begin to do a two-stand technique for distal left main. With the decay cross, reverse decay cross, the left main go to the circumflex. What? And the last result. Also, I think the last result look very good when we can compare with the pre-PCI. And I think this guy, in the view of the technique, not very difficult. You see? And by now, I like to solve two case with the instant stenosis, what's beside repeat revascularization. And most of case instant stenosis. I remind in the presentation of Dr. Michael Lee, Dr. Michael Lee have a talk very clearly and meticulous So I remind very quickly. The first, we have a long time Moran system classification for instant stenosis according to coronary angiogram. Pattern 1, focal. Pattern 2, diffuse. Pattern 3, proliferative. And pattern 4, occlusion. This classification on the basis of coronary angiogram. But nowadays we have the mechanism of instant stenosis or more detailed, more meticulous, and more exactly. The first, the group of biological neoatherosclerosis drug-resistant hypersensitive neointima, and group 2, the technical mechanism apply blood rupture, fracture, geographic mix under expansion. I think that similar to Dr. Michael, my presentation multicolor. And this is the reason why we need one more classification of instant stenosis. The first prior classification on the basis of angiography, but by now we have intravascular imaging. And the first classification would be on the basis of bare metal stent. By now, bare metal stent not exists. And we have intravascular imaging is cornerstone to define. And this Wattman classification will build in the mechanism. So it helps us to understand the mechanism of failure to guide the individual treatment option. So we have the Wattman classification: type 1 mechanical, type 2 biological, type 3 mixed pattern, type 4 CTO, and type 5 multiple stent layer. We go quickly in type 1. We have on type 1A under expansion and type 1-2 stent fracture, and with type 2 biolosis, type 1, type 2A neointimal hyplasia, type 2B neoatherosclerosis without calcify, and type 2C neoatherosclerosis with calcify. Type 3 mixed mechanism between type 1 and type 2. And type 4, you can see CTO have the difference with the previous slide. We don't have the demonstration for intravascular image because it's a CTO. You cannot record IVERT or OCT. You still record IVERT OCT after you open the lesion. And type 5 multiple stent layer. And I have two case for demonstration. The first case with the type 4 and 5 instant stenosis. Type 4 is mean total occlusion, and type 5 on the basis of having many greater than 2 layers of stent. You can see here the patient after 5 years ago, the stent indented to the coronary artery disease. By now, compared with the total occlusion of the stent of the distal RCA and mid vessel. And we must wiring through, and we must do pre-dilatation to record intravascular image. So after we open the CTO, we use the IVERT and OCT to determine mechanism leading to restenosis. Here you can see this is OCT. You can see a 2-layer stent. And you can see after we open the lesion, plaque burden of the atherosclerosis is very large. The patient have two reasons for stenting, the distal and the proximal. And proximal is okay, and one layer of stent, but some pre-stenosis, but not significant. But the distal, you can see two layer stent. But this vessel, the last vessel, so I think we can manage. It's not very difficult. Calcify. So we continue to use the cutting balloon to cut the lesion. After that, we use NC balloon and we stenting. And this is the last result pre-PCI and post-PCI. And this is the image. Let's see. Because the assistant doctor not enough strong, so they inject the contrast not strong. It's slur. But we can see the no plaque burden inside the lesion. I think it's okay. So why? And this is the stenting proximal region. It's okay. And the case number 2, you can see after 1 year stenting the LAD, it by now a total occlusion. The first, we try to rewiring, and to open the lumen. It's okay. And by now, we use the second technique of intravascular imaging, IVAS. IVAS, you can see in the basin. The distal segment. We can see pre-stenosis before stent. Because go in the stent, you can see re-stenosis. After we cut the balloon, one layer stent, along plaque burden, large plaque burden along the stent. And we have overlapping stent. So this area, you see 2 layer stent. You see very clearly. One layer stent. Because large burden of plaque, we do one more stent. So by now it become, if it recurrent restenosis, it become a type 5. The last result, it looked very good. And this is the intravascular image. But now you see two-layer stent. And in the overlapping region, you can see three-layer stent. Two-layer stent. Look like three-layer stent in the overlapping. So this is the last result compared with the before intervention. So some take-home message for the young interventionist. Nowadays, in daily practice, the interventional cardiologists encounter non-small amount of repeat revascularization, including previous stenting or bypass grafting. The frequency about 10 to 15%, not small. The technique of PCI is more difficult and challenging, and outcome and prognosis often worse than first revascularization. And interventional cardiology choose strategy of revascularization on many factors, coronary anatomy, and previous technique. Their skill and experience, the patient preference, and comorbidity of patient. And intravascular imaging can provide useful information to guide treatment decision. Young interventionists should learn knowledge in interpretation of angiogram, intravascular imaging, and learn to utilize necessary toolkit. Okay, thank you so much for your attention.
Great, Dr. Dong, excellent presentation, and thank you so much. You talked about the use of intracoronary imaging. How often do you use intracoronary imaging to guide your PCI?
Yeah, you asked me in the situation instant stenosis or okay?
All cases, let's say yeah. Non-ISR cases, what percent of the time do you use intravascular imaging to guide PCI?
I think about 10%. 10%. I use the intravascular imaging to guide the treatment. About 10% for the case, complex case, or for the repeat revascularization, or for very calcified lesion, or maybe after we are stenting something wrong, we use. So only 10%. I think less than Dr. Vũ Hồng Vũ of UMC.
Right. And is there any reason why you would not use more, or you feel pretty confident that you have full stent expansion, in particular those soft lesions as opposed to calcified lesions?
Yes. In calcified lesion, we use the cutting balloon, a scoring balloon, rotor ablator. And I have one question for Dr. Michaeli and Dr. Sandeep Nathan. Today in my presentation, I present 3 case, easy case, but in reality, I encounter some very difficult case with the type 4 and 5 restenosis, such as the patient have two or three layer stent already, and by now the patient have a restenosis with the mechanism is under expansion. And in Vietnam by now we have only cutting and scoring balloon. We have rotor ablator, but rotor ablator we don't dare to do in the long and tortuous the stent. So we have only to measure drug eluting stent and drug coated balloon. Finish. So the patient have this situation. They recurrent instant stenosis 3 times, 4 times, and when he come back to our cath lab, I just only open by the balloon and to do the drug coated balloon. It finished. But I hope and I hear about lithotripsy in America. It can solve this because when I use the NC balloon with very high 24, 25, 30 atmosphere, we cannot open the under expansion stand already because it's very hot. So can you give me advice in this situation?
Yeah, what I would do if, first of all, IVL would be a great application, although there's a paucity of data. But number two, do you have laser in your cath lab?
No.
Okay. Well, if you did have laser, sometimes we like to give contrast while doing laser because you could cause micro explosions to help expand a stent, let's say, because there's calcium. There are some newer balloons where the rated burst is almost 50 atmospheres. So going very high pressure, but if he has recurrent ISR, I think surgical revascularization should be considered. Sandeep, I'll open it to you.
Yeah, Michael, I agree with that. I have some slides actually in my presentation, so maybe I'll just defer a full answer until then. We have used C2IVL, and before the coronary balloon was available, we've used the below the knee peripheral balloon in coronary arteries that are appropriate size. It becomes an issue of diminishing returns, in my opinion, in the situation where you have 3 layers of metal. If you have 1 layer of metal and it's underexpanded, I think that contrast lasing and shockwave both work pretty well. I think if you've got multiple layers of metal, as Michael said, I would be thinking about the OPN NC balloon, which is now finally made its way into the United States. That's the balloon with the rated burst pressure of 50 atmospheres.
50 atmosphere. Oh.
50.
Which is comparable to what you get with an IVL balloon. Obviously, though, with IVL, you could inflate at 4 atmospheres and cause very little barotrauma. At this point, I'd like to open up to the other panelists. Do we have any other questions for Dr. Dung?
I have some comments. So in our physiology, in all of us, physiology to prevent is much more better than treat method. So to prevent the instant restenosis, so do we think that we use for hundreds of cases of the intravascular imaging for guiding, such as Japanese style? We can prevent almost of the instant restenosis. So do you think this is a good idea?
For me?
Yes, for Dr. Houghton.
Yeah. I think before I have some measure of intravascular imaging, I think I can do many cases without intravascular imaging. But particularly some case with instant restenosis, we can perform only on the coronary angiogram. But with some case, I saw in the coronary angiogram look like no under expansion stent. Just I think it's the restenosis due to neo-atherosclerosis. But when I use IVL, oh, surprisingly, not neo-atherosclerosis, is under expansion. So, but nowadays, with all the case with instant restenosis, we always use intravascular imaging. Similarly, in some case with complex PCI, it means a very, very calcified lesion. We do the rotablator, we do cutting balloon, and when we perform coronary angiogram, it looks very well, it looks excellent. But when we do the IVI, something must repair. So I think in all the case with difficult case or complex case, we should use intravascular imaging.
And not all.
Yeah, can I get the panel's responses? what are your, how frequently do you use intravascular imaging to guide all your PCIs? Is it 10%? Is it 60%? Is it in select cases? Can I just get some people's responses as to how often intracoronary imaging is used?
In my center in Hanoi, Vietnam National Heart Institute, we just only use less than 10%. Just only some selected case like instant restenosis for left main or some calcification case. I think one of the very important reason here in Vietnam is nowadays the reimbursement from the insurance not covered by all, just only some very specific indication like that. Yeah.
What
Michael,
about laser? Yeah, I'm sorry. Sandy, please go ahead.
Yeah, no, I was just going to say, you know, this is such a limiting aspect of intravascular imaging in America as well. The reimbursement's not great, and you know, it adds time to the procedure. I think it's the right thing to do for a lot of cases, not just the complex cases. And so our use of intravascular imaging in our lab has risen to, I think, overall about 60% of cases. For me personally, it's about 75% of cases uses some form of intravascular imaging. But you know, without reimbursement, it's really tough to get the rest of the country on board. I think nationally, it's probably in the 10 to maybe 15% range now. Historically, it's been under 10%.
Now, switching over to the concept of, let's say, some of the cases that you presented, Dr. Don, where there was a lot of plaque burden or a lot of neonatal hyperplasia, and also to get other people's thoughts of the role of debulking. Is there any role of debulking in select cases? And the data doesn't really support its use, especially in current day, but is there any role of debulking with laser? Sandy, I'll ask you just because you have laser available at your institution. So what are your thoughts?
Yeah, boy, I mean, it's a great question. I mean, I think you'll get lots of different answers depending on familiarity and institutional success rates. As you correctly mentioned, there is a paucity of data. And so it really becomes, in our institution, in our hands, how well does it work? I think that for long lesions, for diffuse ISR, and for what would historically be classified as a Moran class 4 lesion, a complete occlusion, it's probably worthwhile lasing. I think that laser is also very useful if you have a mix of expanded and unexpanded stent. So if you're going to use it for an underexpanded stent and use contrast lasing, why not just start with a laser and just lase the entire thing? Try to get as much debulking as possible. In the past, probably 15 years ago, I was using more rotational atherectomy for ISR, but there is a very real risk of burr entrapment and stent ablation. So if you've got areas of exposed stent, it's not without complications, as I think everyone is aware. Going through a prior stent or multiple layers of stent with rotational atherectomy. So that's gone down, but our laser use has gone way up. How about you guys?
I intend to have a question, but Dr. Sandeep Nathi, you have just talked. I like to ask you about your experience to use rotablator in debulking the plaque burden. Because in Vietnam by now we have just only rotablator, and some case with stent regret, but very short stent regret and a stress and a big diameter, large diameter. I intend to try the debulking with rotablator. It's okay. How about your idea?
Yeah, I mean, I think rotablator is fine. If you want to have a meaningful result in debulking, you're going to have to use a larger burr, a minimum of 1.5 and preferably 1.75, depending, of course, on the size of the vessel. Going through it with a 1.25 really doesn't do a whole lot in terms of debulking. One could also argue that the use of orbital atherectomy may be beneficial in a mix of neointimal hyperplasia and underexpanded stent, for the simple reason that the histologic data and the OCT data shows that you induce fractures in calcium. So it's off-label in the United States and everywhere. There's been a small body of experience with using orbital atherectomy. As I said, I think rotational atherectomy is fine. It's useful in certain cases, but we have shifted more towards lasing these and typically starting with either a 1.4 or 1.7 millimeter laser fiber. So something a little bit larger than what we would typically use.
Yes, in my case, case number 1 and number 2, I don't remember exactly. With the very large burden of the plug, a long, big stand and very long, and we must use many times a cut balloon, because if we did not cut the balloon or carefully, the stand cannot the second stand cannot expand fully. But after the last result, it have a slow flow phenomenon, but not due to thrombus, I think due to debris of the plug go distal. Okay, thank you so much.
Yeah, we have 2 more minutes, 1 more minute before Dr. Nathan gives his talk. Any final closing thoughts or questions? Dr. Dung, any thoughts or final questions or? Okay, all right. Our next speaker is Dr. Sandeep Nathan from University of Chicago, who will talk about strategies for repeat revascularization after balloon angioplasty and stenting.
Well, thank you very much. Can you see my slides okay?
Yes.
Great. Big thanks to Dr. Tak Nguyen and the organizers of this meeting, Vietnam Society of Interventional Cardiology. It's truly a pleasure to be with you this evening for us, morning for you. And so in the next 15 minutes, I will discuss strategies for repeat revascularization after balloon angioplasty and stenting, and touch upon some of the contemporary management strategies for ISR. Now, many of the prior speakers have already made several of these points, so I will skip over some of the content that's already been presented. Here are my disclosures. Okay, so just basics. To take a step back here, what is the scope of the problem? We're devoting an entire session to this, this issue. Do we really need to talk about this? I would say absolutely yes. Stent failure, broadly defined, refers to a variety of mechanisms that ultimately result in target lesion revascularization. We are focusing on in-stent restenosis, but it's important to recognize that stent thrombosis can happen as a freestanding event. Most of it is clinical, some of it is subclinical, and then organizes and becomes a late occlusion of the stent that's discovered later. Extrinsic compression, either through intramyocardial bridges, post-surgical, and ingrowth of calcium nodules, which I'll discuss here in just a few slides. Stent fracture has been mentioned multiple times as a nidus for both in-stent restenosis as well as stent thrombosis. And at the end of the day, ISR remains the most common cause of stent failure after PCI. We all remember the days of bare metal stents where restenosis rates varied greatly with the type of stents that were used, the type of coating, and the strut thickness. There have been several elegant studies that have linked stent strut thickness with bare metal stents. There's a direct proportionality. And so in the current era of thin strut and ultra thin strut stents, that's off the picture. And of course, the addition of drug and bio neutral polymers have improved this greatly, but it still remains a pretty significant problem in the United States and in Europe. So this is data from 2 separate studies or sets of studies. On the left is 5 million PCIs from NCDR from the United States that were analyzed, showing that overall rates of in-stent restenosis over 2009 to 2017 have remained relatively stable. So it's about 10.6% of PCIs in the United States are performed for ISR, and about 5% of PCIs performed in Europe. are for ISR, and there's obviously some variability from country. And this is what the analytics look like for that study. 5 million records, bare metal stent in-stent restenosis declined, and DES ISR rose. In the United States, believe it or not, there are still many labs that use bare metal stents because of concerns about short duration of dual antiplatelet therapy and compliance and so forth. I think that's misguided. The data would suggest that there is neither safety nor efficacy with bare metal stents from a ISR or a stent thrombosis perspective. And so we've largely abandoned the use of bare metal stents for many years now. Patients with ISR PCI were less likely to present with STEMI or non-STEMI than non-ISR PCI. And overall, the outcomes were pretty comparable. Who are the patients who go on to have in-stent restenosis, the folks who we should really be vigilant of? Well, here is sort of a laundry list of different variables that have been identified in different studies as increasing the risk of in-stent restenosis. Diabetes and hemoglobin A1C as a continuous variable seems to predict in-stent restenosis. Dyslipidemia, that's unfortunately everybody. High sensitivity C-reactive protein and hyperhomocystinemia, smaller stents, longer stents, coronary bifurcations and trifurcations. ESRD and heavily calcified lesions, we'll come back to that because that's I think a very interesting subset of patients. Osteal, RCA, LAD, and SVG lesions all seem to be ISR prone. And if you have a history of prior ISR, unfortunately, that predicts future ISR as well. In the Issam Musa study that I shared with you a few slides ago, these are the risk factors associated with ISR PCI versus non-ISR PCI. This has already been discussed exhaustively. I think it's the one thing I would add is that it's important to remember that Roxana Moran's classification system was published in 1999, and it was derived from bare metal stent in-stent restenosis lesions in 245 patients. Angiographic accuracy was verified by IVUS in a subset of these patients. I think going into the era of drug-eluting stents, which in the United States began in 2003, we assumed that we could just sort of carry this, this criteria over, and what we saw with BMS ISR was going to be the same as what we saw with DES ISR. Some contemporary definitions that have also been carried over from a bygone era to now is a 50% luminal loss, diametric stenosis, which translates to a greater than 70% loss of cross-sectional area by IVUS, any form of intravascular imaging, greater than 75% loss of cross-sectional areas compared to a reference vessel area, matches up pretty well with autopsy findings. But really, what I want to emphasize here is that ISR should be considered a biological continuum rather than a dichotomous diagnosis. So yes or no, black or white, 1 or 0, it should really be considered as a pathophysiologic continuum. It's probably far more complex than we're giving it credit for. And clinical restenosis, we all recognize, represents a subset of overall restenosis. Fully 50% of patients with restenosis never come to clinical recognition. You've seen the slide already in Dr. Lee's presentation. We can sort of look at it a couple of different ways. We can look at it in terms of the biology of disease. Is it neointimal hyperplasia, which going from bare metal stents to drug-eluting stents, we assumed that this is what was happening. But as it turns out, it's not. A lot of neoatherosclerosis associated with mechanical factors, plus minus mechanical factors, seems to drive restenosis in drug-eluting stent patients. Another table on the right of this slide juxtaposes bare metal stent restenosis with drug-eluting stent restenosis, and histologically there are some pretty substantial differences between these two. So while it's tempting to sort of lump this together and say, you know, restenosis is restenosis, that's probably not true, and I'll share with you some OCT data to support that statement. You've already seen Ron Waxman's ISR classification based on DES restenosis. I think it is important for us to become familiar with this because it does take us in different directions in terms of treatment. So let's dive a little bit further into what some of these factors are. So we can sort of split this into stent-based factors, intra-stent factors, and extra-stent factors. Stent factors on the left of the slide include underexpansion and undersizing of stents. This often happens if intravascular imaging or at least high pressure dilatation isn't being used for the initial procedure. Intra-stent factors include neointimal hyperplasia, neoatherosclerosis, calcification, and thrombus, and the severity of obstruction. Calcification is interesting. I'll talk about that in just a couple of slides, because we assume that once the stent is in, you can have calcium behind the stent, but you really shouldn't have calcium inside a stent. And there's some new observations from a Japanese group that challenged that issue. Okay, so then extra stent factors are shown here: multiple stent layers, vesicle calcification, calcified nodules, and residual plaque burden. So here's the study that I alluded to. It's a very elegant and provocative study. It's from a Japanese group that essentially analyzed plaque that was retrieved using a directional coronary atherectomy system that's used in Japan. We don't have it here in the United States, but in dialysis and non-dialysis patients, they analyzed the plaque that was retrieved during atherectomy. And as it turns out, calcified nodules in the plaque within the stent seems to actually be quite prevalent in dialysis patients. So this is a completely different mechanism of restenosis than what we typically consider. We've all observed extrinsic compression of stents by growing calcium nodules. There's a patient that I take care of that has had this happen multiple times, unfortunately, in his left main stent. And the last time we had to actually go through a freshly deployed core valve to open up the left main once again, this time using shockwave IVL. But there are substantial differences, and the authors propose that perhaps at early, midterm, and late stages, there are different biological mechanisms that are actually driving the protrusion, not the extrinsic compression, but the protrusion of calcium through stents. So calcium nodules essentially forming through the stent and then becoming a sort of a subvariant of neoatherosclerosis. So this gives us some food for thought, because perhaps in dialysis patients and ESRD patients, we should be tackling this issue slightly differently. So why use intravascular imaging in ISR PCI? Well, because angiography doesn't correlate with biology, physiology, or three-dimensional vessel structure. Our eyes are simply not that good. When we compare IVUS and OCT for this purpose, there's obviously some pretty substantial differences. I think OCT wins by way of tissue characterization. IVUS is quick, it's cheaper in many labs, it's widely available, but you don't get tissue characterization. And so being able to delineate neointimal hyperplasia from neoatherosclerosis becomes a little bit more challenging with intravascular ultrasound. Here are some distinct tissue patterns in ISR that have been described. So, you know, this is what we sort of think about when we think about ISR, this homogeneous neointimal proliferation. But if you look at C and D, these are some of the typical pictures of neoatherosclerosis. And here you have a mix of neoatherosclerosis as well as this homogeneous pattern, as well as coronary thrombosis as well. So the more you look, the more you find, and it drives you in slightly different directions. IVUS usage is great as well. Use something for in-stent restenosis work. Across the board, IVUS usage improves outcomes. This is a sub-study of ADAPT DES, not necessarily in-stent restenosis patients, but these data have been recapitulated in multiple studies at this point. Here's what else OCT can tell you. So we worked very hard to get this RCA CTO open, and at the end of the day, it just didn't look right. And right now, what we're looking at here is stent fracture with plaque protrusion. So there's a complete disarticulation of the stent there. This isn't the fresh stent that we put down. Now, we were fairly aggressive at post-dilating the stent. I apologize for the fact that this looks like a colonoscopy, but it does show very nicely where the plaque protrusion is and the stent fracture is. So, if you put an OCT catheter down, even after the procedure is done, you'll often find many things that are going to cause problems. I would also say that prevention of ISR is far better than treatment of ISR. And this frequently happens in the setting of STEMI PCI, primary PCI. So this is a young guy, anterior STEMI. We sized the stent for the vessel, which was admittedly a little bit vasoconstricted. We get a vessel that looks like this. And essentially, you've got a mix of plaque protrusion, thrombus, and undersizing and malapposition. So pretty much everything that sets the stage for problems down the road is easily demonstrable once you put an IVUS catheter down. And after aggressive dilation with a 4.5 millimeter balloon all the way into the left main, you get a much more satisfactory result, both by angiography and by IVUS. So these are the kind of lesions that will come back later as in-stent restenosis. In the last few minutes, let me talk about the landscape and chronology of ISR therapies. This is a very elegant figure from a review article that basically lays out from 1997 to 2021, nearly 25 years of therapy for in-stent restenosis, and the color of the circles and the perimeter and so forth are described here. Going from the days of balloon angioplasty and restenting with bare metal stents to vascular brachytherapy with both beta and gamma, rotablation, cutting balloon, drug-eluting stents, and now the era of drug-coated balloons that's available outside of the United States. We have a wealth of information. Practically speaking, in the United States, this is what we have to deal with. We've got semi-compliant and non-compliant balloons. We've got cutting elements, scoring elements. Atheroablative techniques, we typically will defer to, we'll prefer to use rotablator rather than orbital atherectomy or laser, and now shockwave. And this all sort of falls under lesion prep, and then finishing the case with either DES or a drug-coated balloon, which we don't have in the United States, although I am guilty of putting peripheral drug-coated balloons in coronary arteries once in a while when I'm really desperate and the vessel is big enough. I would make a plug for laser in severe or diffuse in-stent restenosis. So what you have here, we've got dual cannulation for this LAD CTO, which involves a stent that is both undersized and restenosed. And so we used a combination of contrast and non-contrast laser using a 1.4 millimeter fiber to achieve this result. So in these types of lesions where there's complete occlusion of the vessel, I would say that laser is a very useful tool. Shockwave is also being increasingly used. We have quite a bit of institutional experience with shockwave. This is what shockwave looks like on the bench. The essential concept is that electrical energy is delivered to the two lithotripters, creating a steam bubble which expands and rapidly collapses. And the estimated pressure, instantaneous pressure, is about 50 atmospheres to the vessel wall. And if you look at this case that was included in Disrupt C83, what you find is that in de novo disease, the fractures go very, very deep into the vessel. So look at this OCT. The fractures go very deep into the vessel. If you've got one, perhaps even two layers of metal, you should be able to get pretty good fracturing. We've demonstrated in our own lab, both with IVUS and OCT, where plates of calcium are breaking up despite a prior stent being in there. So this is an excellent option for underexpanded stents or a mix of fibrous tissue and underexpanded stents, calcium behind the stent. In the last 2 minutes or so, I'll just share with you a very high-level summary of what all of these therapies sort of bring. Intravascular brachytherapy, as Michael has already mentioned, is out. We don't use it in our lab because of the catch-up. You don't actually treat the restenosis. You just slow it down for a year or so, and then it comes right back. Rotational atherectomy as a standalone therapy, probably no value beyond it's better than balloon angioplasty, not better than drug-eluting stents. DES is our preferred approach in the majority of cases, outside of maybe just very, very focal restenosis that we can treat with a high-pressure balloon. DES is sort of our default therapy. Paclitaxel has fallen by the wayside. There isn't adequate comparison of the different limus analogs for us to know if there's a clear winner. We typically will use a hetero DES strategy. What that means is we use a different drug and a different device than the one that restenosed. There are many proponents of a homo DES strategy where you put in the same exact type of DES and you just blow it up a little bit bigger. But our preference is to switch stents if one of them has restenosed. Drug-coated balloons, there's a lot of data that's accruing. We don't have a single large trial that definitively says that drug-coated balloons are better or worse than the different types of DES. And now there are so many drug-eluting stents on the market, I don't know that that trial will ever be done. And drug-eluting stents versus drug-coated balloon angioplasty trials, it's really interesting because, in a meta-analysis, DES reduced the need for subsequent TLR compared with paclitaxel drug-coated balloons at 3 years. But it's interesting because the relative efficacy of these treatments may have something to do with the original stent that was put down. So think about the slide that I put up, suggesting that there are substantial biologic differences between BMS-ISR and DES-ISR. In patients with BMS-ISR, clinical efficacy seems to be exactly the same for drug-coated balloons. So maybe that's a preferential treatment strategy. You've all seen this proposed algorithm. Here's a simplified one. I think Dr. Waxman's algorithm is very elegant and very meticulous. Here's a simplified one. And the key take-home points are shown next to it. Know the type of stent that was used originally. That's extremely helpful. The size and the make and the model and so forth. No details of the original PCI. Perhaps there were things that were omitted or overlooked that'll help you get through this and get a durable result. In our lab, we would always image the lesion beforehand, always, 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 with the exception of a CTO where you can't get imaging in. We would always image the lesion first, so long as something will pass it. Consider invasive physiology, particularly for long segment disease, simply because our eyes aren't that good. If you've got long segment 50% disease, make sure that it actually needs to be done before you do it. First, address any mechanical issues, stent sizing, expansion, calcium behind the stent. Next, decide on ablative therapies, rotational atherectomy, laser, or a combination of laser and shockwave. Finally, decide on DCB versus DES. Practically speaking, in the United States, it's DES, but there's at least 3 manufacturers that are enthusiastic about bringing their products to the United States. And then finally, always image the final result. It may look good, but you're setting the stage for more ISR if it also doesn't look good on intravascular imaging. I'll stop there and thank you so much for your attention.
Thank you, Sandeep, for very detailed and excellent presentation about the ISR. And because today our topic is about optimal PCI, so I think the take-home message slide from Sandeep is a key point for the patient with the ISR. So because you mentioned about the physiology in the patient with the ISR, so could you tell us about the how you use the IFR, FFR, DPA in the patient with the ISR? Is it similar to the novel lesion, or will have some difficulties or some challenging or some different cut-off before and after PCI? Thank you.
Yeah, thank you for that question. It's a great question. We use it in a similar capacity, but the point that I wanted to raise is that many times when you've got homogeneous distribution of neointimal hyperplasia, we look at it and we say, yeah, it's a long lesion, it's 50%, it's probably significant. When you actually do an IFR pullback, and my preference is IFR simply because you don't have to use adenosine and you do get reproducible pullbacks. When you do an IFR pullback, you realize that the majority of the physiologic significance is coming from one area. it's not as homogeneous as you actually think it is. That's application number one. Application number two, invariably in long segment lesions, side branches are going to be involved. And so we will typically IFR, if possible, the side branches just to understand how important will it be to protect it, particularly as we ablate through that area. What's the likelihood that we're going to get ischemic in a large diagonal, a large obtuse marginal, and should we do something about it proactively before we treat the parent vessel?
So thank you, Sandeep. And another question also about the optimal PCI. I know that your IVUS penetration in the center is very high, and how about the IVUS criteria for the in-center restenosis? So for the second PCI, what is it similar to the novel lesion or different from the novel lesion?
Yeah, it is similar. Typically what we'll do is we'll size the stent based on an average of the proximal and distal reference diameter. So we'll find the proximal and distal reference diameter, take the average of that and say that this is the minimum size that we need the stent to be. Very often what we'll find is that the first stent that was put in, it's a little bit small. I mean, it looks angiographically like, there's no taper, particularly if you use something like stent boost, you get a very good image of the stent. Angiographically, it looks okay. The IVUS usually tells a different story. I think it gets a little bit tricky, of course, when you've got stent, you've got a stent that's deployed in calcium. And at that point, to the question that was raised earlier, what do you do if you don't have OPN NC, if you don't have shockwave? Take the shortest balloon that you can actually find, whether it's an angiosculpt balloon or whether it's preferably an NC balloon. Take the shortest balloon that you can actually, you can find and focus on that area that you've identified with IVUS. A very aggressive move, and we've done this a couple of times, a handful of times, is granatoplasty. So granatoplasty is the colloquial term for deliberately blowing up a balloon there. When that balloon ruptures, it's going to send, shock waves deep inside the calcium. But there is a pretty significant risk of perforation, but we've had to do that when we can't get any of these other technologies to pass.
So thank you, Sandeep. So the last question from me is that I know that the OCT is better than the IVUS in the ISR patient to see the mechanism of the stent failure. And because in my cath lab, I don't have the OCT in the Professor Dũng center, and we only have the high definition IVUS. So in your opinion, is it high definition IVUS? Is this good to determine the stent failure mechanism compared to the OCT in your experience? Thank you.
Yeah, no, it's OCT makes very elegant images so long as the technique is good, right? If the technique is good, you get nothing. You waste some dye and you get images that are almost uninterpretable. So we tend to use more IVUS in our lab than OCT, and we actually don't have the high definition IVUS yet because we have the integrated IVUS in all of the labs already. So I haven't been able to convince my administration to buy me a high definition IVUS because we already have the other one. I think if you have high definition IVUS, that solves a lot of problems. I think that's just fine.
So thank you, Sandeep. So any question from the speaker and panelists for Sandeep about the excellent presentation from Sandeep?
Hello, I may have a question. So in case of the type 5 CTO of instant restoration, do you use tools crossbot and Stingray?
Yeah, we do use some crossbots and Stingray, but the nice thing is that you've got, particularly with stent boost and even without stent boost, so long as it's not an ultra thin strut stent, you should know where the boundaries of the lesion are. So we're more in the camp of using microcatheters and aggressive wires. So typically I'll start with a Gaia 2, go to a Gaia 3, and then just step up to a Hornet 14 or some very sharp pointy wire, and then navigate through there. If we're having issues where we're stalling or there's calcium, then we'll consider switching back to crossboss. But typically, our crossboss usage, I think, is more in native in de novo CTOs rather than ISR CTO. What's been your experience? How do you approach it?
It's a very few cases, but I am heard that in the case of the instant restenosis, the CTOs, crossboss S3, they may have some work. Thank you.
So thank you, Professor Hung. And because we over 2 minutes already for the next presentation, so it's my honor to introduce the next speakers. Dr. Nguyen Hung, he's a Vice Director of the Interventional Cardiology Department from Chợ Hospital, the biggest hospital in the south of Vietnam. He's also the expert on the complex PCI and CTO and also rotablation atherectomy. So he will tell us about the repeat revascularization post PCI and CABG surgery. Please, Dr. Nguyen Hung, please. Thank you.
Yes, thank you very much for the introduction. Good morning, everyone, and good evening, the colleagues from the US. So we went through a lot of important presentation already. So my presentation is a little bit different with yours. Okay. So this is the guideline from the Europe that we use the IVUS imaging in order to OCT in order to optimize the mechanism of the ISR in real time. So the revascularization failure is usually the early graft failure. The second one is the acute percutaneous coronary intervention failure, like a stent fracture or significantly residual stenosis. So the third one is the disease progression and late graft failure. We have to redo the coronary artery bypass graft or we do the PCI. So a lot of presentation already mentioned about the PCI for the severe vein graft or for the native vessel, but today I present something a little bit different. So repeat PCI may be the stent thrombosis as well, and restenosis and disease progression. So, but I just mentioning about the disease progression after the open heart surgery. That's my presentation today. So usually we the patient go to the hospital because they have the some symptom or some sign, and we have the indication for repeat revascularization. So with that, we can send the patient for the bypass surgery again, or we do the PCI. So this is a recommendation from the Europe already mentioned from the previous presentation already. So I don't want to mention about again. So with the patient, this is the paper presented that published in the JICC about 2 years ago. So we say that the patient already undergone the bypass surgery, so they don't want to proceed the bypass again. Only around 10% they want they had the indication of bypass again. So the rest, about 90%, more than 90% of the patient had to redo the reverse by the PCI. So with the PCI, so usually we have to repeat the PCI. Only 20% of cases we had to send the patient for the bypass. Of course, there is a high risk after the patient have to undergo the repeat revascularization procedure. So usually have the high risk for the procedure. So the trends of the repeat revascularization choice in the inpatient prior coronary bypass surgery is the patient undergoing the redo bypass surgery are more complex and associated with the worse clinical outcomes than those receiving PCI. So repeat PCI for aortocoronary CTO lesion after an open heart surgery. This is my presentation today. So we have some cases to present to you that with the AOCC, the aortocoronary CTOs lesion are the rare around just around 0.04% to 0.4%. So the lesion are the usually good candidates for CABG in patients with the previous CABG or the other open heart surgery, reopen surgery, or only high risk operation for the surgeon and for the patient as well. And AOCC lesion are always very high, very tough lesion for interventionalists, and medical literature has reported a few cases so far. So the first case, the 61-year-old gentleman, he had the chief complaint is the CCS class 4, mean that the unstable angina. So the patient had the history of the underwent the WIT procedure for ascending aorta aneurysm and severe bicuspid aortic regurgitation. And the surgeon put the left internal memory artery, the limb graft to the distal left anterior descending artery due to the mid to proximal LED stenosis, and another reason is the middle LED muscular bridge 2 years before. So now the patient came to the hospital because of the chest pain, and this is the angio before the this is the aneurysm of the ascending aorta. And before the operation, they send the patient to our lab to do the coronary intervention, coronary angioplasty. Coronary angiogram. So this is the left man is normal. So the lesion is proximal to mid LED, and of course this is the muscular bridge. So they put the graph to here. So this is another view of the left coronary artery. The right side is normal. So 2 years later, the patient come back with this and with the symptom as well. So the left man is totally uploaded, and this is the graph put into the this is the WIT procedure. The WIT procedure is that replace the haunting from the ascending aorta, and this is the left man trunk already disappear, and this is the angiogram from the limb. But the patient has the symptoms, so maybe the limb to just supply the blood to the mid LED, and the rest of the thing is the patient has suffered from the ischemia. So this is another view of the angiogram. So we didn't see any clue of the left man trunk. So we do the retrograde from the limb to LED, and then go back to the left man here and go through to the aorta, and then we did the intervention to open it up again, the circumflex territory, and this is the final result. So another case, a 70-year-old gentleman, he developed the chest pain for 1 year. The patient was on optimal medical treatment, but he still have the typically exertional chest pain, CCS class 3. And this is the cardiovascular factors, ex-smoker, dyslipidemia, and the past medical and surgical history is the mitral and aortic mechanical valve replacement in 2008. It means that around 10 years before that, 10 years back. So EKG shows that the AFib and QA and inverted T-way in the D1 and AVL, and ejection fraction still okay at rest, but the hypokinesia at the symptom when we increase the heart rate a little bit. So this is the echo. This is the echo. This is the X-ray. You can see the valves here, 2 valves are here already. So the surgeons send the patient to us because the patient had the symptom. So we didn't see any clue of the left man trunk on the aortogram. So this is the valve we can see on the, and this is the right side. The right coronary artery is still still okay, no lesion, but we didn't see any clue of the left main. So we see the collateral from the right to the left side and up to here, and the left main already uploaded 100% for around 1 year. So we have indication for the intervention repeat reverse again for this patient, and we have only one choice, that we go from the right to the left side up to here and open the left main again for the patient. So this is the hybrid algorithm for the interventionist. So we did the devices we are used for the patient. Of course, the left side we did just put the JL guiding catheter standby there, but without any engagement to the left main trunk. So we go from the right side to the left side, and we use the at first I use the AL for the right side, but the after that the patient developed hypotension, so I have to switch to the chair again. This is the algorithm, so we don't have any chance to go from the left side, so we have to go from the right side. So retrograde 100%. So we think about the cut or reverse cut. Reverse cut are not applicable due to the obliteration of the left main. So we 100% go from the right side to the left side. That the strategy for this patient. So I use the JR after to replace the AL because the patient developed symptoms. So I use the JR in order to go use the STR and cross the septal to the right, to the left side. And this is the AL catheter, make the patient blood pressure of the patient drop. So we have to think about the something's happening for the patient. So this is the reason. So the AL compressing on the aortic valve. So the patient developed symptom, and we have to replace this catheter right away before continuing doing the procedure. So this is the we have to replace this catheter to the chair. I know that the chair catheter is quite very quick backup, but we don't have any other choice to use this. So we have to use the chair. So anyway, very fortunately, we success cross the collateral, and then we use the Gaia second to cross the left main CDO to the aortic root like this. So now the catheter is stay away from the valve. So this is the reason that the patient develops symptom when we put the catheter to the aortic valve. So this is the wire go through the right side to the left side and then go to the aortic root. The catheter here is just the landmark for the procedure without any engagement into the left main. So successfully cross the left main with the concave patty, and then we put the wire attentionalization to the subclavian artery, and then to the crease, and then the next step as usual manner. So this is the final result. So we open the left main again for the patient, and the patient developed didn't have any symptom anymore after this procedure. So that is my take-home messages. The patient undergoing radial CABG are more complex and associated with worse clinical outcomes than those receiving PCI. That is coming from the paper around the world. Now, repeat revascularization by PCI is a good alternative method in this situation. through a controlled retrograde technique may be the only choice for chronic obliteration of the left main coronary artery, especially on high-risk repeat CABG patient. Thank you very much for your attention.
Well, thank you. That was a tour de force. That was many very complicated cases. Congratulations on superb outcomes. If I could start, I have two questions for you. One is, what is your experience? Do you have experience opening up chronically occluded saphenous vein grafts? And similarly, to keep with the theme of today's discussion on restenosis, when a vein graft restenosis, do you approach it any differently than native restenosis?
Yes, thank you very much for your for the questions. With the total occlusion of the vein graft, so I don't want to open it up. I try to open the native vessel because the total occlusion of the vein graft is very high risk for the perforation. And of course, when you can cross that lesion and the slow flow or no reflow after that is very high. So usually I don't want to open the vein graft total occlusion, but I try to open the native vessel again with the same territory that's applied by the vein graft. Thank you.
Thank you. I have one other comment, and I don't know if you have any experience with this technique that's been described by Bill Nicholson called ECART, so electrocautery assisted reentry. And the idea is basically, it's very high risk, admittedly, but you take a very sharp wire, you go as far as you can, and then you connect the back of the wire, you strip the coating off of it, connect the back of the wire to a cautery device, to a bovie. So the flat paddle of the bovie goes onto the back of the wire with a clamp, and then you apply energy to go through a chronic total occlusion. I don't know whether that has been done in Vietnam. It's very few centers in the United States have tried that for obvious reasons.
Yes, very new to me as well. So I hope that one day I can learn from your side.
Oh no, I mean we don't do enough of those kinds of procedures to teach anybody. It's but it is sort of an interesting concept, and it's the same idea that's been applied to basilica for tearing bioprosthetic valves before TAVR, essentially using electrocautery to burn your way through the valve leaflet. The same thing can be done in a coronary artery. Thank you for a fantastic talk. I'll open it up to the other panelists. Comments or questions?
So Dr. Hong, just want to ask patients after bypass surgery, and then certainly we found restenosis as anastomosis of lima to LED. So then in these situations, any difference of PCI of lima anastomosis to LED? And also I would like to hear experience from Dr. Sandeep Nathan also.
Yes, for the patient with the width procedure, they before doing that, they send the patient to the cath lab to do the angiography in order to see that they need to put a graft to the LED or not. So there was the indication for grabbing the LED, but the very distal to the LED. That means that the supply for the distal territory of the LED. But the 1 year later, not the 2 year after procedure, the patient developed chest pain and very the patient had symptoms, severe symptoms. So maybe the circumflex territory is the culprit. The anatomy is okay. With the lateral view, the anatomy is okay. So, and I didn't think that the anatomy is the problem, but the progression of the disease from the left main is the main one. So I have to open the left main to the circumflex and the proximal LED diagonal. The graft to the distal LED is still patent, so I don't want to touch that, but they use that way to go through the retrograde because the left main is totally occluded. Without any glue, that we use the anti-grade approach. Thank you.
Did I understand the question the question was about Lima anastomoses, is that right? PCI of Lima anastomoses?
Yes, please.
Yeah. So I mean, I think there's a few technical notes there, a few technical considerations. One is the amount of tortuosity in the Lima. You'll easily be able to get a stent down there, but often when you're working on that lesion, if you're using any adjunctive equipment like lasers, and we've taken laser fibers down the Lima, sometimes you get enough pseudo lesions that now you don't have flow anymore in the Lima. The Lima is fine, but you just don't have any more flow in it. So be prepared for that. The second is the distortion of that anastomosis, the angle that you're entering the typically the LAD. That can be a little bit challenging. And then the last thing is that sizing your stent to be suitable for the LAD, but also for the Lima, recognizing that other than the anastomosis, the Lima is almost always going to be a non-atherosclerotic vessel. So 16 atmospheres with an oversized stent in a Lima is not a great idea. So, there again, I think you just have to be a little bit cautious about how you approach the portion of the stent that lands inside the IMA graft.
Thank you.
Other questions or comments? I think we've got 2 more minutes before we move on to the next speaker. Dr. Nguyen, any thoughts or comments?
You see, they do amazing things. I'm really impressed. Very nice, And they did that without impeller.
Yeah, no,
and
it's
also I see that Dr. Ngomindong, he was praised because his catheter touched the prosthetic aortic valve.
yes.
If he can embolize the valve, leaflet. We are very careful about that. You see?
It is, you're exactly right. I think it's remarkable how little interaction with a prosthetic valve is enough to cause problems. I've actually put an FFR wire across it, and that was enough to hold one of the leaflets open, torrential AI, hemodynamic compromise, literally within 60 seconds. And, we just pulled the wire out, and fortunately it was fine. But, doesn't take much. Okay, well, if there are no other questions, I think we stay on time and we move on to the next speaker, Dr. Majid Kanbur, who's going to share with us tips and tricks in revascularization.
Thank you. Thank you for the invitation, Dr. Nguyen. So should I try to share my screen here?
Hello, technical team. Can you help Dr. Kanbur to share screen?
Yeah, I think I got it here. 1 second. Can you see it now?
Yes. Hello, Manji. You are in charge now.
Thank you. So, yeah, I mean, I agree. I think the treatment of restenosis, instant restenosis, I think it starts with prevention. I think it's trying to do it the right way from the first time, especially, when we, think that under expansion of the stent is the most common reason why we have instant restenosis. So doing it right from the first time, and that I think comes through 2 main things. Number 1 is using of imaging. And number 2 is lesion preparation, especially for calcified lesions. So I'm going to talk a little bit about lesion preparation. So in the drug-eluting stent time, the primary importance, the lesion preparation is very important. Coronary calcium is one of the major determinant of PCI failure and has been correlated to late adverse events. So correct positioning of the drug-eluting stent is crucial point of optimal revascularization, avoiding long-term adverse outcomes, which is mainly, again, because inadequate expansion. And that's, of course, most of the time results of incorrect preparation of the lesion. It's the nightmare, of course, calcium. It's very challenging. Around 1/3 of all lesions, if you use angiogram, around 1/3 of those lesions are calcified. If you use IVUS, it increases to around 75%. Of course, trying to treat heavy calcified lesions with balloon inflation, that's also a risk for dissections. There's so many ways way of treating calcified lesions, traditional balloons, compliant, non-compliant balloons. You guys talked about angiosculpt, scoring balloons, atherectomy, rotation, rotablation, and CSI. So all of these ways to treat calcium may not be effective in all calcified lesions. You know that calcium can be, eccentric or concentric. A lot of times, these atherectomy devices that we use, it can just take care of the superficial calcium. And now we have shockwave. That's the only way maybe to treat deep calcium. Scoring, cutting balloons, high pressure balloons, they're still limited in their ability to modify calcium. If you try to dilate eccentric calcium, that sometimes results in expansion bias toward the non-calcified segment of the artery. Thick, deep, concentric calcium is unable to, have required force to liberate vascular compliance. So they're all limited. Laser is a way. I use laser actually only during my training. I haven't used it since that time. It's approved for coronary intervention around 20 years ago. The system emits pulses of ultraviolet light, has relatively limited tissue penetration and can cause plaque disintegration without injury to the Bieber media or adventitia. Most common catheter used for coronary interventions are 0.9 millimeter. To minimize the risk of injury to the dissections or perforation that caused by laser, usually continuous saline infusion during laser is recommended. Sometimes some speakers mentioned that you use contrast in addition or replacement of saline, especially for underexpanded stents. This is a case we did. 78 years old male came in with non-STEMI, had PCI to the right coronary artery. So he has 2 layers of stents already. So sorry. So in this case, so 2 layers of stents already. We're able to wire. We ballooned, no good results with ballooning. We used rotablation, also, with just a very modest improvement. We decided to use laser. Even with laser, we are able to get good results here. But I mean, it's not. It still has some around maybe 50% in the mid RCA. But the patient had already 2 layers of stents. So that's with laser, balloon, and non-compliant balloons and rotablation. Another case, a 66-year-old male had CABG a long time ago, had PCI to the circ, his vein graft to the RCA occluded, and had patent lima-2-LED. Had PCI for instance stenosis to the RCA in 2003 and 2016, and now presented with chest pain and has unstable angina. So again, already 2 layers of stents. This is the left coronary system. Circ is okay, lima is open, and this is his right coronary artery. You can see there is severe instant stenosis mid RCA, a little bit also in the distal RCA. This lima is open. So yeah, we used, we started with balloon inflation, non-compliant balloons, no good results. We switched to rotablation. We used 2 millimeter burr. We did 2 runs. Even after that, it's a little bit of improvement, but not much. And then we decided at that time, this case was done when Shockwave was not approved in the US. I think it's around 2020. It was approved, I think, last year. So we used the below the knee Shockwave. So the peripheral Shockwave balloon, we use it for this case. So it's 4.0 by 60 Shockwave balloon. We ballooned, distal to the proximal RCA. Total of 80 pulses were delivered. And we had pretty good results after that. And then that distal part of the RCA, we used another 5.0 balloon and 5.0 by 20 non-compliant balloon. And this is the final result. This is another case, 69 years old, CABG in 2018, came in with an unstable angina, lima-2-LED is open. His vein graft to the obtuse marginal is occluded. So he had also already 2 stents he started in the left main into the circumflex. In this case, we also used everything we have. So this is, you can see this is severe instant stenosis in this area, left main into the left circumflex. And we started with non-compliant balloons. We did rotablation actually here, 1.75 burr. I think maybe we should have gone to 2. And then we did Shockwave as well. Final results are acceptable. So most of those complex cases, instant stenosis, especially when you have already 2 layers of stents, you probably need to use more than 1 modality to get a good result. So talking about calcium, if you have calcium angiographically, if it's mild, you probably don't need to do anything, just regular balloon, non-compliant, and then in case it failed, then you can go ahead and go to other modalities. In general, if it's moderate to severe, you go ahead with image. If the calcium arc is less than 270, then you can try to start with just regular balloons and stenting. If the calcium arc is more than 270, then it's preferably that you should do some sort of calcium modification through atherectomy or nowadays shockwave therapy. So shockwave is a novel device that we can use in patients with calcified lesions. Started in Europe, was approved in 2017. The US approved the coronary use for shockwave last year. The idea behind it delivers localized pulsatile sonic pressure waves, modifying calcified lesions in a safe manner. It produces high-speed sonic pressure waves that pass through the soft tissue to selectively disrupt calcium. Be very similar to the urologic extracorporeal lithotripsy, but IVL differs by expressing a focal effect with ultra-high energy. So the waves travel outside the balloon. This is the balloon. The wave travel outside the balloon, designed to disrupt both. The good thing about it, that's talked about, that CSI and rotablation, it modifies superficial calcium, luminal calcium. However, the lithotripsy or shock wave is unique in a way that it also can reach deep calcium. This is the device. This is how it looks like. As my other colleagues mentioned, it produces around 50 atmosphere pressure. We have many, currently have many balloons, so it's the 1-4 compatible device. Start with 4 atmospheres, nominal pressure 6 atmospheres, rated burst pressure is around 10. The working length is 138 centimeter, and it's 6 French sheets compatible. Start from 2.5 millimeter. It is one length, 12 millimeter, and then it starts from 2.5 diameter up to 4 millimeter. This is how it looks like. This is the balloon, semi-compliant. You have 2 marker bands, 1, 2 here, and then the 2 emitters in the middle. This is how the catheter looks like. Approval came in, after the Disrupt the CAD study. This study included patients with stable angina, unstable angina, or silent ischemia. 60 patients. And overall, it's safe. There was 0 dissection. There was no perforation and no reflow. This is the complications we see sometimes in atherectomy, in rotational atherectomy and CSI. This is another case, 40-year-old male came in with unstable angina, past medical history of CAD and PCI to the right coronary artery around a year ago before this procedure. It looks like he had this done at like outside facility. Looks like he had bifurcation stenting here at the distal RCA. Not really sure, maybe DK crush, but from the distal RCA and PLB and the PDA. And he has severe instant restenosis in that posterolateral branch proximally. This is an example of why IVUS is important. This is undersized stent. I think it's like around 2 to 5 millimeter stent. This is the distal RCA. We actually couldn't pass the IVUS past that lesion. So this is from the distal RCA. And I think it's probably 4 millimeter or 2.5 stent in a 4 millimeter vessel. So we tried to balloon and used all kind of balloons. We didn't really, we got acceptable results. We didn't want to keep trying much. Shockwave, like in this case, one of the, not a problem, but shockwave balloon is, it's not easy to deliver, especially in the severely calcified stenotic lesions. So we didn't even attempt to deliver it here. This is the final results after ballooning. This is what I have. Thank you.
Yes. Thank you very much for your excellent presentation. As you mentioned, deep interest in the revascularization is very important, and the lesion variation is very important, and the role of the intracoronary imaging as well. So I have one question for you. If we don't have the imaging during PCI, can you share your opinion with one, for example, AC balloon, scoring or casting balloon, or rotator? Which one will you choose if we have characteristic lesion in angiography only?
Which balloon to use?
Yes, with balloon or scoring or IVL or rotator, which one would you choose?
So, yeah, so now we have shockwave. So most of the time we start with shockwave. So I used to use scoring balloons. Not much lately. So we start with non-compliant balloon, and then it depends on the results. I decide most of the time go with shock.
Yes. So because if we have the intracoronary imaging, we can identify the characteristic lesion. So can choose the AC balloon or scoring balloons or rotator for this lesion. So if we don't have imaging in this situation, could you share your opinion? Which one will you choose in the characteristic lesion if you have only angiography?
If you have only angiography, what balloon would you use?
Yes, because intracoronary imaging not popular in our cath labs. Just one 50 to about 10 to 50% the reason for intracoronary imaging. So could you share your opinion? Which one would you choose in this situation?
So you know what? Even here, like I think our use, Dr. Duyan is with us at the hospital. Our use for IVUS or imaging is very, very small. I think around 20-25%. That's me. But looking at angiogram, if there is so much calcium on, if I just this is calcified lesion just based on angiogram, most of the time, so I start with regular balloon, compliant balloon. Next step usually is non-compliant balloon, and after that a shockwave. Scoring balloons, cutting balloons. To be honest with you, I didn't use it much. And again, after the now we have an available shockwave, my use for these balloons is 0.
Yes, thank you. Any comment from the panelists? Can you give a comment or a discussion with Dr. Ken Boer? Dr. Ngô Minh Hùng, you have any opinion about these topics?
Yes, thank you very much. I think I had a question for for the for this presentation that in some situation we have to use the high pressure balloon. Of course, it is very often in the clinical practice, but I heard that you guys has the 50 ATM atmosphere super high pressure balloon. So in this situation, so we can go with 50, 40 or 50 ATM. But what do you think about the damage of the stent already implanted inside the vessel? So it damaged the metal of the stent, or it damaged the polymer of the stent. So what are your recommendation about the pressure on this situation? Do we need to go with super high pressure, or what is the prognosis of this? Thank you.
Thank you. So if it's in-stent restenosis, I think that going with the high pressure balloon is acceptable, because eventually the goal is that if it's one layer of a stent, you use that high pressure balloon, you open up the vessel to be able to put another stent. If you already have 2 layers of stent, then I think there is nothing you lose here. It's an old stent. The drug is not there anymore. It's just the goal is usually to achieve short-term results and have symptomatic relief for the patient. I don't know what do you guys use atherectomy for ISR, rotablation or CSI?
Yes, I'm mentioning about the post procedure. Right away, post the procedure, we have the residual stenosis. So in this situation, we use a super high pressure balloon. So in this situation, we have to think about the polymer injury with the high pressure balloon. With the previous stent, a couple of years, a couple of months before that is okay because we don't lose anything. But in this situation, I just mentioning about because sometimes we inflate we put the stenting and we receive the residual stenting significantly. So this is my question. Thank you.
Yes, I agree with you. I think the goal is, number one, is to have good lesion preparation, so you don't have to go through this situation. But in case you do, which it happens, then I think there is some people say, like nowadays for shockwave, for example, that we can't use it in a freshly placed stent. There was a question about that those shockwave may also have some damage to the stent rod and the drug availability. But if you put a stent and it's still there is a severe lesion going up to using high pressure balloon, it's going to do damage to the stent, no question about it. But what's the alternative? Leaving that stenosis? That I think you're going to choose between this two. I don't know, one good, one bad. I don't see any problem using that.
Yes.
Yes, thank you.
Thank you, Dr. Hung, and thank you, Dr. Campbell, with your answer. Any question from the panelists and the chairman, please? Also now, if we have no question from the panelist and the chairman, I would like Dr. Đinh Đức Quý will presentation with title Cutting or Coring Balloon Angioplasty combined with the DCB to treat in-stent restenosis. Dr. Quý, please. Unmute, please, Dr. Quý.
Okay, so thank you, Professor Dũng and the organizer to allow me to attend this meeting. So my next 15 minutes presentation is about using a cutting or scoring balloon combined with a drug-coated balloon to treat in-stent restenosis. So I believe that's for the in-stent restenosis of today, we only see a lot of overlapping slide. So first one, we all agree that with the imaging now, we can decide the in-stent restenosis mechanism. So as you can see on the picture here, we can find neo-intimal hyperplasia, or even a ruptured thin caps with the underlying cavities of red thrombi, causing major distal shadowing of the stent. And then based on the OCT imaging, that we can know the mechanism of in-stent restenosis. Here we can see some of the histopathology or also the characteristic features of in-stent restenosis, and then it can help us to determine the treatment strategy. For bare metal stent and drug-eluting stent, there is some difference in the mechanism of restenosis. Mainly, bare metal stent restenosis can happen after a few months after implantations, maybe 6 to 9 months. But for drug-eluting stent, we can see the ongoing lead loss to 5 years. And then we have a lot of things to concern when we do PCI for in-stent restenosis than stent factors, intra-stent factors, or extra-stent factors. And when we treat the in-stent restenosis, the aim is to maximize the QGANT and minimize the lumen loss. And the most important parameter when we comparing drug stent and drug-coated balloon to treat the in-stent restenosis is net gain. So this is what we got after we minus the QGANT to the lead loss during the follow-up of PCI. So this is some pictures of when we do drug stent or drug-coated balloon for in-stent restenosis, we may see a QGANT of drug stent a bit bigger than drug-coated balloon for in-stent restenosis. But by maybe a year after follow-ups, we can have the same minimal lumen diameter of drug stent or drug-coated balloon to treat the in-stent restenosis. So the slides is already shown in the previous speaker talk. So we have a lot of clinical study to assessing the treatment of in-stent restenosis from the bare metal stent to drug-eluting stent in-stent restenosis. We have a lot of devices like intravascular brachytherapy, rotoablation, also preparing the lesions by cutting or scoring balloon, and then after that you can apply the drug stent or drug-coated balloon. So the very traditional device to treat in-stent restenosis is just plain balloon angioplasty. But anyway, this can be considered as Achilles heel of PCI because it's associated with age-related complications and a higher recurrence of in-stent restenosis. Maybe it's can up to 50%. With the new generations of non-compliance balloons now, we can go to pressures as high as 40 or 50 atmosphere during PCI of in-stent restenosis. Normally for in-stent restenosis, we can use short a non-compliance balloon to prevent longitudinal barotomas. And I think during the PCI of in-stent restenosis, the effort should be made to avoid age-related complications and slippage of balloon outside the stent of what we call a watermelon shedding phenomenon. And to fix this kind of watermelon shedding phenomenon, we have two more devices as cutting and scoring balloon. So the cutting balloons use multiple plates that anchor the device in the lesions and avoiding this kind of effect with the advantage of cutting the neo-intima tissue. And also the scoring balloon, they employ low profile nitinol whites on the surface of balloon in a spiral formations and help to minimize barotromas to vessel wall and slippage of a conventional balloon when inflated over the scar tissue. So this is what we got from the study. You can see the similar results of drug stent and drug-coated balloon of treating in-stent restenosis, and both of those devices are more effective than balloon angioplasty alone for in-stent restenosis. And based on the guidelines of the ESC 2018, drug stent and drug-coated balloons are both class 1A indications to treat the in-stent restenosis for both bare metal stent or drug-eluting stent. And this is from the year of 2017 when we see if we prepare the lesions by scoring balloon, neo-intimal modifications of the plug, we then can improve the anti-restenosis efficacy of a drug-coated balloon. So this is in segment percentage diameter stenosis of the scoring balloon compared with the control one. So p-value here is reach the significant statistic. And there's a study from the Japanese colleagues to compare the non-slip element balloon or scoring balloon to just blend balloon preparations of in-stent restenosis. So the non-slip element balloons are combine the three layer of Y here, and the expectation of this design of balloon is achieved to a larger lumen area due to the elements, as well as reduce the balloon slippage. And this is a study of more than 200 patients in 17 centers in Japan, and randomized of 1:1 with non-slipper elements pre-dilatations versus just traditional POBA pre-dilatations before the drug-coated balloons was applied. And the primary endpoint is in-segment dead loss, means the post-minimal lumen diameter minus to the follow-up minimal lumen diameter. So this is a patient characteristic. So the mean age of 70, we see 50% of diabetes in both non-slipper elements balloon and the POBA. Patients CKD in around 1/5 of patient. And you can see here the acute gain was significantly larger in the NSE group balloon, but after 8 months of follow-up, the in-segment lead loss was similar between the two groups. And we see drug stent versus bare metal stent, or hemodialysis versus non-hemodialysis, first ISR versus repeat ISR, or big stent of more than 2.5, or small stent less than 2.5, or diabetes versus non-diabetes. There's no difference in the lead lumen loss of the two group. So what is the advantages of non-slipper elements balloon? Based on the balloon slippage, only 7.9% versus the 22.9%, and geographic miss 6.9% versus 21.9% of the POBA group. So the conclusions of the elegant study is that 8 months and geographic outcomes were similar in between the non-SE and non-compliant balloons pre-dilatations with drug-coated balloon for treatment of in-stent restenosis lesion. However, the non-slipper element pre-dilatations has advantages of reduction of balloon slippage and geographic miss during procedure. This is a study by the Chinese colleagues to compare cutting balloon combined with drug-coated balloon in the treatment of in-stent restenosis. So when you see the Kaplan-Meier of 1 year TNR, there was no difference in between of cutting balloon angioplasty plus DCB and in the group of DCB alone. We also have a long-term follow-up, 5-year results of cutting or scoring balloon before we apply a drug-eluting balloon to treat in-stent restenosis. This is the data from the Spain colleagues of 107 ISR lesions of 91 patients treated with drug-coated balloon. There was 51 lesions was treated with cutting balloon or scoring balloon and then DCB, and 56 lesions with standard DCB. 53 lesions was treated with sequence please device, and the other 54 with the Panterax Lux. All was a paclitaxel drug-coated balloon. And the primary endpoints were clinically driven target lesions revascularizations at 5 years. And this is the results. So compare with the standard DEB, the cutting balloons show lower of TLR at 5 years with P of 0.05. So it's not reached the statistically non-significant reach. And if we compare the Kaplan-Meier incident of time until TLR show the similar results and similar rates of TLR at 1 year. There was no stent thrombosis was reported with the two group. And the conclusions from the study is that in the real world setting, the neo-intimal modification with cutting balloon before DEB versus standard DEB to treat in-stent restenosis show lower, although statistic non-significant rates of TI at 5 years. And this benefit has been confirmed in the long term and is consistent with bare metal and drug-eluting stent. So this is what's meant in stent restenosis classifications with definition and treatment options. So we have a biologics type 2 with neo-arteriosclerosis. We call time C. Then we can think of using a cutting or scoring balloon, and then after that, it's DCB. So in summary, to treat the in-stent restenosis, we need to define the pattern of lesions. Is that bare metal stent in-stent restenosis or drug stent in-stent restenosis? And then intravascular imaging can help us to identify the underlying mechanism. And then each of our interventionists need to know the techniques and when to use them in the management of in-stent restenosis. DCB so far is a proven therapy to treat in-stent restenosis. And then if we can prepare the lesions by cutting or scoring balloon prior to DCB to modify the neo-intimal plaque, it may lead to a better angiographic or clinical outcomes. So thank you for your attention.
Hello, Dr. Kenvor. You are moderator.
Oh, me? All right. Well, thank you very much for this talk. Any questions?
Yes, may I have one question for Dr. Linda Kui? As you know, in Vietnam, we have in the toolkit for calcified lesion, we have just only to measure the first, the cutting balloon or scoring balloon, and the second is atherectomy with the protoblator. And you have data from RCT with only cutting or scoring balloon. But in clinical practice, we often combination between cutting or scoring balloon with the protoblator. So do you have any data about us? And can you give us your comment how we compile a combination between a cutting scoring balloon with protoblator in practice?
Thank you very much for the question. I think it's a tough situations because the rotablations is considered contraindications within the stent. I think it's not strict contraindications, but I think it should not be the first option when we choose to modify the plaque. So I don't know, is there any kind of data related the rotablations in stent segment? So I want to hear from other faculties. But anyway, I think during my practice, we do see patients that we need to use both of cutting, scoring balloon, and rotablations to prepare the blood. In case that we cannot open the lesions, especially calcified lesions within in-stent restenosis. I have just a very few experiences in this kind of situations when we have to rota after we fail with all kind of balloon, NC, cutting, scoring balloon that we cannot open. So I think the last option will be rotablation.
I agree that rota should be. It's not the first line at all. Not even here. All these rota cases we did, it's all failed balloon, high balloon inflation, and it's because number one, there is no data, about use of rotablation and stent. And in fact, as you said, it's contraindication. If you ask the company, it's one of the labels that it's contraindicated to be used in stent. So it's off-label, and there is only just the case reports here and there, but there is no real data about ISR, any kind of atherectomy, whether it's CSI or rotablation. So it is not the first line, and I think the main concern is the complications, the potential of something bad happens if you use it. So we've seen cases where the burr gets stuck. You may get lucky and be able to get it out, but a lot of times, sometimes you can't, and either patient dies or they just have to go for emergent bypass surgery. So it's I think balloon inflation, whether it's just non-compliant regular balloons, high balloon inflations, or scoring balloons, is number one and first line. And only in cases where you don't get good results, then you should consider other modalities.
Yeah, thank you. I'd like to hear some comment from Dr. Ngô Minh Hùng. Combination, not combination.
Yes, thank you very much, Professor Dũng. I had a question based on the last point, take a message from Dr. Đinh Đức Huy that we should we look at the pattern of the ISR. So I'm thinking about the thin stent or super thin stent ISR compared to the normal stent like more than 80 micron or even 140 micron like a Cypher more than around 20 years ago. So do we need to classify again that the ISR with the very thin stent struck or the normal stent normal stent struck or not? Thank you very much.
Okay. Also, another difficult question, because we all know that with our new generations of thin or very thin struck DES, like ultra thin, less than 70 micron of truck stent, then we have a very good result of follow-up. Even after I think it's 5 years, based on the data from SCAR registry, then the rate of in-stent restenosis is low. It can be considered very low. So I think it's mainly now we see DES in-stent restenosis on patients with older generations like Cypher, Texas, and Endeavor. I think the very first generations of drug stent, and now they just come back and have we treat them. I think we may need a few years more to see patients with new generations like Osiro or Sierra Giants. Do they also present back again with in-stent restenosis? In daily practice, I have to say that we still see some of in-stent restenosis with the new generations, but mainly because I think of the smaller size of the stent, because we don't base on the imaging, but we just based on what we find on angiographic, and sometimes we choose a smaller stent than the diameter, the real diameter of the vessel. And then I think in this case, it's just easy work for the operator. Just use a bigger balloon to open the stent again. Thank you.
Hello, may I have questions to Dr. Đinh Đức Huy? So, do you have any strategy for the choosing the tool to do for in-stent restenosis? If you decide which case to use cutting a scoring balloon, which case you just only use for the routine with the non-compliant balloon, and which just you use something else? Do you routinely intravascular imaging?
Yes, thank you very much, Professor Phạm Anh Hùng, for the question. So first of all, imaging is always the options that says in Sandip, Dr. Sandip taught we need to use, but sometimes because of like in Vietnam, because of reimbursement, so not on the case that can be apply the imaging for ISR PCI. So a second thing, if I see a very focal in-stent restenosis, like just 1 or 2 mm of restenosis within the stent, then definitely I would choose a cutting a scoring balloon, because I don't want to see a slippage watermelon phenomenon of the balloon on the lesions. But if I have, I think, a longer restenosis, then I will start with a traditional balloon, and after that, it's the NC balloon. And then the imaging in this kind of situations will help me to answer the question: is that the lesion is have the enough preparations before I apply DCB or not?
Can I have another question?
Yes, please.
Yes, we usually think that when we put too many DCB for the patient, so we're worrying about the toxicity of the drug to the body, to the patient's body. So according to your knowledge and experience about this DCB, so in the same procedure, so how many DCB can we use for the patient in order to stay away from the toxicity? Thank you very much.
Another question that we don't have a definite answer. So I believe that a few years ago, there's some data from the Spain colleagues that show that even you apply the 2 kind of drug in the same vessel, like limus stent, and then after Taxel or paclitaxel, and then when you overlap a long in-stent restenosis with the 2 drug balloon, that's no harm in clinical follow-up of patients. I think that it's a big issue for drug, even with drug balloon or drug stent, because most of drug stent or drug balloon, they calculate exactly the quantity of drug to put in a balloon or a stent. But truly, I don't know how it can affect of the patient's outcomes.
No, actually, I asking that the question because the drug coating balloon is a little bit different with the drug coated stent, because the drug coating balloon is we just release the almost 100% of the drug to the vessel right away at the time we deploy the balloon, but the stent is slowly release the drug to the body, so the body of the patient can tolerate with the concentration of medication compared with the DCB that right away did release the drug to the vessel and then go to the whole body. Thank you.
If we have experience from the drug-coated balloons in the peripherals before, and there was that signal about increased mortality in people who had drug-coated balloons in the legs a few years ago. But that turns not to be the case, and there was a study that said like, no, that's not true, and there is really no increase in mortality in any patients who had drug-coated balloons for the legs. And remember, for the balloons of the legs is much larger balloons. I think the concentration for the drug is much higher than the ones that's used for the coronaries. So I don't think we have any data or evidence that there is any harm of using more than 1 drug-coated balloons for the coronaries.
I think in a few cases we need to overlap the drug-coated balloon because of long lesions of in-stent restenosis. Because the longest drug-coated balloon we have here in Vietnam, I believe that is a 30 mm sequence please balloon. So in case that you have a 40 mm, 50 mm length of in-stent restenosis, and you don't want to implant more drug stent, So I think the only option is to do a 2 drug-coated balloon, and then there's definitely a place that we need to overlap the 2 drug balloon. So far I don't see any harm for patients.
I think that if we don't have any more questions, let me continue to give my talk. Is it okay?
You're the boss.
Because Manjit is new to this kind of meetings, as I understand. So I do this. I do the sharing now. Okay. So what I'm doing now is just I share my current research on restenosis. So the first one it is what I'm doing now when I do a procedure. I try my best to be sure that we avoid in-stent restenosis as much as we can. And if we see there is some obstruction within 24 hours or less than 30 days, it is a mechanical problem, or the patient did not take medication correctly. It's very important. In this one, for the first 30 days, it's our technique. Did we do a good job on deploying the stent? Now, if it is in between 1 to 3 months, at that time, we have early post-angioplasty or in-stent restenosis. Especially, this is the experience with bare metal stent. It's of 1 month to 3 months, it is in-stent restenosis. After 6 months, most of the time, we don't have any more restenosis. Another one, I'd like to remind the audience, the doctors, that the scar tissue inside the stent is a living tissue. So it can grow and it can regress. It's not just because we do the angiogram and we see some blockage, then we have to put a stent. It's not true. It grows and it can regress. So what I do research now, I say, what accelerates the thrombotic process in the first 30 days? We have to be sure the patient take medication, and then we have to be sure how we can delay the in-stent restenosis process. So again, all the time I use hydraulic data and principles, and if we do anything in an artery with a laminar flow, we know we can almost prevent in-stent restenosis. Right now at my practice, I have very few in-stent restenosis. Here it is a case, this is the arteries, I did the angioplasty 11 years ago of the LAD. And we have a lesion in the circumflex. We didn't fix it. And as the patient is on medication, very good medication for high blood pressure, high medication for high cholesterol level, and the patient achieved good results. You see, 11 years later, the lesion still beautiful. No more severe lesion. Now, then, like in this case, this patient, she had a lesion in mid-LAD. It's a young woman, 35 years old. I was so surprised when I saw the lesion because the stress test was negative and the patient kept complaining of chest pain. So we did a stent, we put a stent, and the result come out as best as it can be, and she was stable for the last 6 years. The key for prevention of in-stent restenosis is the patient on P2Y12 inhibitor. Then the patient compliant with medication to control the blood pressure and to control the diabetes and to have LDL level less than 75. I strongly saw strongly that if the patient had no high blood pressure, perfect cholesterol level, and no smoking, the chance for in-stent restenosis is very low, almost none. So here, let's see now here, this patient, we have a severe lesion in the in the ostium of the LAD. Because the lesion is so sharp, the border is so sharp and clean. That means this patient does not have unstable angina, ACS. The patient has stable angina because the lesion is so stable. And here we see that the flow, the laminar flow across the lesion, and I did the FFR, it was negative. This was 5 years ago. So a few years later, the patient came back with the same complaint. FFR negative, and the lesion with, and we see here in the second one, the laminar flow across the lesion. So we did the gastroscopy, and the patient has a Schatzki rings and peptic ulcer disease. And we treat the stomach problem very well, never come back because of the heart problem. Now I show the next one. I showed this before. This patient has severe lesion in the ostium of the LAD, and we see the flow here. And then we put the stent, and I did the angiogram twice. After the stent, and 2 years later, stable, wide open. So the key, we have to do a good job, good flow, laminar flow after stenting. And the patient had to control, to have the blood pressure well controlled, the cholesterol level well controlled, and no smoking, diabetes with a good hemoglobin A1C, and then no in-stent restenosis. Now the patient I have here is this patient had this angioplasty at the LAD more than 15 years ago. And he had a lesion in the right coronary artery. But because of distance, right now I'm doing a study from this kind of a lesion. What's the difference between the lesion at the mid-segment and the lesion at distal RCA? And we see that if this patient had blood pressure very well controlled, cholesterol level very well controlled, and the lesion does not, the patient did not progress, still stable. I love to do the angiogram again, but the patient is asymptomatic, and he is in his, in his 80 now. So he is not interested to have the angiogram done, and I did not insist. But in general, this patient, very stable, even the lesion is severe, if we control with making. Now, right now I look at my latest part of the research, it is when we have a lesion in the proximal segment, if there is rupture of the plaque, where it will be? Is it the entry shoulder of the lesion or the distal or the exit shoulder? Here we have the left main, we have a lesion here, and we have at beginning, look at that, at the beginning, this is the diastolic and in systole, the flow go in very slow and didn't move further until, and this is number 4, in diastole, the flow go very fast. And the lesion, the plaque rupture as the entry shoulder of the lesion. In reverse, if the patient develop a lesion at the distal segment, like in this case, the distal RCA, here we see, I showed this before, mechanism of water hammer shot. We have a tank, a pipe, and a valve. The flow, the valve is open, and the flow, the fluid flows forward. But if we close the valve abruptly, there is, so the flow is stopped abruptly, and so it will have, there is a collision between the antegrade and retrograde flow and cause a shock here, and with high pressure and collision, turbulence, this area will be damaged. This is in the pipe. It happens the same in the arteries. Here we have the lesion which I showed before, and in this artery, here there's a bifurcation at the distal RCA. But in systole, the flow reverses, and the flow reverses and cause a flow separation zone here, and this is the area where we have the lesion. Now we see the flow reverse. Here it is in the distal RCA, and the flow going forward because the blood in white and the contrast in black. And we see the blood moving forward in white. We see the white color here, still white. Now, the next one, we see the flow reverses. The contrast. And you don't have to look at my picture. You go back to your lab and you see the picture in your own lab. I can assure you, you see the reverse flow. If you look at it, it is 15 frames per second, and you look one by one. Okay, so at the end, in conclusion, what I'm doing now, is the first one, like some speaker did mention about that, is better to prevent instant restenosis rather than fix it. I saw that you do impressive job to correct all this instant restenosis. It's not easy. And number one. Number two, what are the key of success in the case? We have to have good flow, laminar flow across the stent. And the patient had to be compliant with medications, control the blood pressure, control the cholesterol level, control the diabetes, and no smoking. I saw that if my patients do that, they don't develop instant restenosis unless I did a bad job with no well opening of the stent and no restoration of laminar flow after stenting. And I mentioned about my new research. If the patient have a lesion in the mid-segment of the coronary artery, if the patient develop ACS, the plaque rupture, it is at the entry shoulder of the lesion. But if the lesion is in the distal segment, the rupture of the plaque happens at the exit shoulder. Thank you very much.
Okay, thank you so much for very excellent presentation from Dr. Thạch Nguyễn. And we heard many presentations of Dr. Thạch Nguyễn about the new or novel theory for coronary artery disease with on the basis of the theory of fluid dynamic. By now, we blood flow for formation of atherosclerosis in coronary artery disease. But by now, today we hear about the application of this theory for explanation and how to prevent in-stent restenosis. Yes, very, very wonderful. And before our panelists and faculty have a question for Dr. Thạch Nguyễn, I have one question. The first, after we do stenting, and we evaluate the blood flow through the stent, and we can see laminar or turbulent flow to predict the in-stent restenosis. Maybe there are many factors contribute to turbulent flow. The first, such as maybe under expansion of stent. Under expansion of stent, it means some parts of stent it protrude to the lumen of vessel, and it can make the turbulence. And maybe design of the stent or the structure of the stent, this stent are different from another stent. So can you predict or can you anticipate for one stenting when we saw the flow go through the new stent, and if it have the finding of turbulent flow, can we recognize that? Can we recognize that? Look like we use the intravascular imaging after we do stenting, and we do optimal stenting. And can you use your technique to see flow go through the new stent, and you can recognize some finding of turbulent flow? Yes or no?
Thank you. I agree. That means after I put a stent, after I deploy a stent, I look carefully at the flow. If we have fast flow, that means we have the fast flow. That means the pressure distal to the stent is lower. This is why we have high flow proximal, low flow, high pressure proximal, and low pressure distal, so the flow is very fast. This is normal FFR. When you see that the FFR is normal, you see? So this is one way. But right now I'm learning. I'm looking at that, and so far the result I saw is very encouraging. So this is one other way. But the key is when you do a procedure, you don't stop and go to the machine and look one by one frame by one frame. So we have to learn, like you know that we are doing now with your team in Vietnam, to do with machine learning, to do for let the computer does for us. This is, but we have to do it by ourselves first, to prove to the other cardiologists, to ourselves. So this is what we are doing now, and I say that the results are very encouraging. That's it from my part.
Okay, thank you so much. There are any question or comment from the panelists about the topic of Dr. Thạch Nguyễn? I think very interesting.
Thank you, Professor Thạch Nguyễn, for the very new and very interesting talk. I would like to ask you how we can distinguish or differences between the reflux from the phenomenon to the slow flow or no reflow. Just a phenomenon we usually met in our daily practice, how we can recognize it. Yeah.
Hello, Hong. Can you repeat the question? You know that I know one it is slow flow distally.
Yes.
After standing, and what else?
Yes, I mean that's something. So you mentioned that we in the phenomenon we get some reflux, right? The reflow come from the distant to the proximal, but I don't understand. Is that due to the slow flow or no reflow phenomenon?
Yeah. So let's say now we have normal arteries.
Yes.
And the patient had high blood pressure, high systolic blood pressure.
Yes.
The patient has reverse flow from high blood pressure. We don't have to be nothing slow flow in here. And the easiest one, I know that you do a lot of radio pressure, radio curve, radio angiogram, angioplasty. If you do the femoral, and after you finish the angiogram, and you do a femoral angiogram and you inject, you see in systole the flow will go down for 2 beats, two frames. And then you see the reverse flow because of uncontrolled high blood pressure. And this is the reverse flow, had nothing to do with slow flow. You see? Now, what about slow flow? Very interesting. So let's say now the artery is clean. Why they have slow flow? The slow flow, it is at the myocardial level. It's not at the arterial vascular level. The obstruction is in the myocardial level. So this is why right now I submit one paper for abstract for the AHA. Remember, Monday is the last day of the submission for abstracts for the AHA. And I saw that patient had elevated troponin level, had chest pain. The angiogram was normal, but the stress test was abnormal. That means the injury is at the myocardial level. So in the same as in the slow flow. In slow flow, after we did the angioplasty, and the plaque is soft, and you just inflate the balloon, and you put a stent, and you flush the debris, small debris distally. The arteries are clean, but the occlusion is at the myocardial level. It goes like that. You see, so I'm working on it, I'm doing research on it. But to answer your question, very simple about reverse flow in systole. So the answer is, doesn't have to be it's not slow flow. You take a normal person with uncontrolled high blood pressure, you will see. Thank you.
Thank you so much.
Okay, is there any? Yeah. Is there any question or comment from the panelists for Dr. Thạch Nguyễn?
Can I have a question for Professor Thạch? I love this theory of hydraulic mechanism. And I just had a question that are you going to set up a virtual algorithm in order to do the virtual angioplasty before we do the real procedure for the patient with the lesion based on your analysis? Thank you.
Interesting. You know that they do the CTA of the cornea angio by CT, and they measure the FFR. This is virtual, you see, and I agree with your interesting concept. I mean, can we do virtual angioplasty first? They can do with the open heart surgery or the surgery for structural heart disease in children. And they use a 3D dimension printer to print the heart, you see? So I believe that your idea is very interesting and new. I will just let you know that number one, one author, they asked me to look at the chapter about the new imaging data for the for coronary arteries, and I contributed that paper, and I present our data. I show the way how we look, and it was reviewed nicely. Maybe in 1 or 2 years, when the book come out, then it go into mainstream. Number two, I will go to Boston in July, and I already arranged some of my friends in Boston at Harvard so that I can present this data. And we are set up time and to present the new technique to show it. You see, so this is to let you know that. The reason why I cannot show to everybody because it's secret, trade secret. I have to get the credit first. If not, some people will take the technique and patent it. That's all. Thank you.
Yes, thank you, Professor.
Okay, thank you so much, Dr. Thạch Nguyễn and Dr. Ngô Minh Hùng. I think the new theory about of Dr. Thạch Nguyễn for explanation and application to treat coronary artery disease is very promising. And by now, we move to the last presentation, the last but not the least, of Dr. Vũ Hồng Vũ, PCI, a patient with prior CABG. Please, Dr. Vũ.
Thank you, Professor Dũng, for kind introduction. My next 10 minutes is about the PCI in a patient with prior CABG surgery. So this is the 64-year-old male patient came to my hospital because of unstable angina, and this patient has risk factors is hypertension, diabetes mellitus type 2, and dyslipidemia. And in the past 9 years ago, he had the CABG surgery at the hospital with three grafts for the CABG surgery. And this is the electrocardiography and the chest X-ray shown that ST depression in some leads, and we have the previous keyway in the D2, D3, and AVF. And the chest X-ray shown that this patient have the cardiac index is high, it's about 0.6. And this is the echocardiography, show the low ejection fraction, 33%, and also we have the dilated left ventricular chamber with LVDD about 69 mm. And finally, we took the patient to the cath lab, and you can appreciate that we have the Lehmann disease, distal Lehmann disease in the left hand side picture, and we have a total occlusion in the circumflex ostium, and we also have the proximal LED ostium of the LED lesion media. This is the media 111, and in the right hand side we see the moderate lesion in the LED middle of LED with the Timmy flow tree. And this is the spider view we saw in the previous slide. We have the total occlusion in the in the circumflex ostium, and we have the left main bifurcation. And in the RCA angiogram, we see here we have the total occlusion in the middle of the RCA. And the Lima and FVG picture, you can see the Lima, we cannot see any graph from the Lima to the LED. In the right hand side, we see the FVG to the big OM. We see here we have the distal, the anastomosis is very significant stenosis at just before the anastomosis. And the question is that we should redo CABG surgery or just do the PCI in this patient. And if we do the PCI for this patient, should we do the SVG intervention, or we do the native artery PCI in this situation? And because this patient will have the left main bifurcation and also have the two CTOs, one in the RCA and one in the left circ. So is it feasible and safe to do the CTO PCI in this kind of patient? So as you have seen in the previous presentation, a lot of slides about the CABG surgery, redo CABG surgery, or redo PCI in the patient prior CABG surgery. And this is the slide meta-analysis compare the outcomes of the PCI for native artery versus the bypass graft. They compare the major adverse cardiac events. You see that in this meta-analysis, we have 14,000 patients, and in the right hand side, you see the benefit if we the favor for the native artery PCI over than the bypass graft PCI. With we can reduce the MACE about 50% if we do the PCI for the native artery. And how about the myocardial infarction endpoint? We also see here the myocardial infarction in the group that we doing the native artery PCI is better than if we do the PCI for the bypass graft with 44% reduction in the myocardial infarction endpoint. And how about the own cause test? If we compare two groups, native artery PCI compared to the bypass graft PCI after in the patient prior CABG surgery, we also see here the own cause test in the group that we do the native artery PCI is the own cause death was lower than the group that we do the PCI for the bypass grafts in the patient prior with CABG surgery. And how about the target vessel revascularization? We also see here the similar result to the own cause of death or myocardial infarction. We see here if we do the PCI for the native artery, is we have the better outcome in terms of target vessel revascularization compared to the bypass graft PCI. And how about the safety? How about the safety of the PCI for the native or the bypass graft? This is the two safety endpoint. The first one, major bleeding, and also the stroke. You see here in the A panel, we have the similar result in the safety in terms of major bleeding, and also the similar result in the term of stroke when we compare two groups, the native artery PCI and bypass graft PCI. So for summarize, we can see this is the 24 observational study comprising over 40,000 patients, and we saw we can see that here the native artery PCI was associated with the lower MACE on cause death, myocardial infarction, and target vessel revascularization, compared to the saphenous vein graft PCI at the medium follow-up of 2 years. So we can review the guidelines from the American. We see here if we do the patient, if in the patient with previous CABG surgery, if we do the PCI for the native coronary artery is visible, then it is reasonable to choose PCI of the native coronary artery over PCI of the SPG disease. And our patient here, we have the CTO, 2 CTO lesion in the RCA and the circumflex. So this is we review this is LATAM CTO registry. They from the Latin American. And so that if we do the CTO PCI in the patient prior CABG surgery, tend to has more comorbidities, higher anatomical complexity, and the success rate is lower than the patient without the prior CABG surgery. And similar in hospital adverse event rate compared to the patient without the CABG surgery. When we do the CTO PCI in the patient without the CABG surgery. So we come back to our patient, and we can see again in the left hand side, we have the retrograde approach from the SVG, and we put 2 Y, 1 Y in the distal runoff of the big OM, and the second Y, and with micro catheter into the circumflex, and we try to do the retrograde approach from the SVG to OM, and anterograde approach Y and retrograde wiring. You can see in the picture. And the final results, we do the decay crust for the Lehmann disease, also the stenting for the circumflex. And you can see here, we can appreciate that the final result is quite good for the Lehmann and also the circumflex. And this is the picture before the PCI and the picture after the PCI. And for the RCA CTO PCI, we stage PCI in this patient 1 month later. Later on the Lehmann CTO, Lehmann circumflex CTO PCI. This is the picture of the wiring and final result of the RCA CTO in this patient. For conclusion, technically is feasible for the native PCI, native artery PCI. If you can do the native artery PCI was associated with the lower MACE cardiac event compared to the SPG PCI, and CTO PCI in a patient with prior CABG surgery is feasible and safe in the daily practice. So thank you for your attention.
Yes, thank you very much for the very good presentation about the CTO intervention after CABG. So I have this question for you before we open this for the panelists and faculty to ask some questions before we go to an end. So I had just had a question that could you retrieve the data that why the surgeon didn't grab the lima to the LED for this patient or not, and in order to make sure that the reason and we had to do right now. And the second question is, why did you do the retrograde for the OM instead of you just put the stent or do the ballooning and put the stent in to the OM right away? And for the left man, we just cross over. It's easier for this very high risk patient that the ejection fraction of the only 43% with the LV DD or almost 60 millimeter in diameter already. Thank you.
Thank you very much, Dr. Hùng, for excellent question about this patient. So the first question is about the Lima to the LED. As you can see in the picture, we cannot see any Lima to the LED in this patient. I don't know the surgeon did the Lima LED graph already or not, but right now I cannot see it. Maybe it's total occlusion, or maybe they do the SPG to LED. But when we do the left main angiogram, we cannot see any retrograde flow to the SPG or retrograde flow to the Lima. And the second question, I think, is very practical, very practical in the daily practice. Because as you see, the FVG, we have very big FVG. We did IVERS for this patient. The FVG is about 5.5 mm. It's a big FVG in this patient, and the OM is about 2.5 in the distal runoff and 275 in the proximal before the SVG anastomosis. So we have the very big discrepancy between the FVG to the OM, and this is the first point. The second point is that we worry about if we put the stent from the SVG to the OM, we don't know where to put the stent, because if we put the stent from the SVG to the distal runoff of the OM, maybe we compromise the whole circumflex before the anastomosis. And if we put the stent from the SVG to the proximal anastomosis, maybe we lose the distal runoff of the OM. So another option is that we put two stents, maybe V stent or something like that, to keep both friends at the anastomosis. But I think for the SVG, we put two stent technique. We don't have any data, and maybe we have some risk of acute total occluded or something like that. So we try to do the difficult thing is that CTO reopen the CTO. I think it's more difficult, but I think it's safer in the long term in this situation. So thank you for very practical question about the strategy to do the native or the SPG PCI. Thank you, Dr. Hùng.
Yes, thank you very much for the question, for the answering my question. Actually, in fact, we had it's up to our operator, but your selection would be very excellent selection for this patient. I open this section to the panelists and faculty that I would like to ask Professor Phạm Mạnh Hùng that has some question about this solution for the patient. Thank you.
Thank you, Dr. Ngô Minh Hùng. To some extent, I agree with you that if the flow to the distal part of the LCH is in okay, so I may ignore the distal part of LCH and just only focus doing on the left main LED and the awesome of LCH. But however, Dr. Vu have a very excellent job with a perfect job. It says okay, but I have another issue concerning about doing the complex case, especially for the repeats, the revascularization for the patient with a prior cabbage. So Dr. Vu, do you usually use mechanical circulation supports in such a high-risk case?
Yes, thank you, Professor Hùng, for the also very practical question about the doing PCI in the high risk patient. So actually, this patient is in the high risk PCI procedure because we have this is the low ejection fraction is 33%, and so the left ventricular enlargement is 69 mm. I think is high risk for this patient. And in daily practice, we don't have the impella. In my cath lab, we only have the IABP balloon for the high risk patient. So in this kind of procedure, I think we should approach three sides. The first one, the radio for the intervention, and second one for the also the retrograde approach from the femoral, and the third one should be the IBB balloon from the femoral also. But in this patient, we didn't use the IBBPs because actually at that time in my cath lab, the IBBP machine was broken, so we cannot use in this patient. But if possible, in the case like this, I recommend, I usually use the IBB balloon during the PCI in this situation. So thank you.
Yes, Professor Hong, do you have any question for Dr. Vo?
Okay, that's fine. Thank you.
Yeah, I would like to ask Professor Dũng and Dr. Tang, do you have any question for this presentation?
Yes.
So
thank you, Dr. Wu. So you have sharing the interesting and challenging case. So I have one question for you. What do you think about stenting for anastomosis lesion? Yes, you can share your opinion and some in data talking about that, please. Yes.
Thank you, my dear friend, Professor Tân, about the experience, our experience about the PCI in the SPG and also the Lima patient after cardiac surgery. Actually, we don't have too much about experience about this situation. We usually do the PCI in the native vessel, but some case we have some case that we the PCI for the native artery, coronary artery disease is not feasible. We cannot approach, so we have to do the PCI for the Lima and for the SPG. And for the Lima, we do the PCI for the Lima, and we have the big problem is that the discrepancy between the Lima, the SPG PCI, we have the big discrepancy between the FPG and the native vessel. So we have to choose the stand. Maybe it's easy to going up to the 5 or 5.5 mm. So we have to choose the stand carefully. And the second one about the distal protection device, we don't use the distal protection device in the SPG PCI. We don't use it, and we don't see any distal embolization or any slow flow after the SPG, but we don't have too much case to do the SPG. And for the PCI in the Lima, we have around 4 cases to do the stenting from the Lima to the LED, and we have the same problem is that when we do the PCI, we worry about the retrograde from to L distal anastomosis and the flow come back to the proximal LED. We worry about the flow. That's the first point. The second point is that during the Lima, we have maybe it's a spasm or something like that. We cannot see any flow during procedure. Maybe we have to do a lot of nitroglycerin or something like that. So in one cases, I did the PCI from the Lima to LED for maybe 5 years ago, and we cannot see any flow, and the patient feel the chest pain on the table. And so at that time, I have to put four stand from the LED to the Lima, 4 stand to the proximal the Lima to reserve the flow and reduce the chest pain for the patient. So that the bad experience about the PCI to the Lima, because during the procedure maybe spasm or harmonic phenomenon or something like that, we cannot see any flow to the LED. Yeah, thank you for your very tough question about that.
Yes, thank
So,
you,
Professor Dũng.
Yeah, maybe my question is the last question. Yes, thank you for very interesting and challenging case of Dr. Vũ Hồng Vũ. And as we know, in the revascularization, the role of IVI in intravascular imaging is very important. But look, it seems in your presentation, you don't mention about IVI. So my question for you, in the case of prior stenting, the IVI very important and not like it can help us to determine the mechanism and the strategy for the treatment. And in the case which look like your case prior CABG, how about the role of IVI in this situation?
Thank you, Professor Dũng, for the question about the intravascular imaging when we do the repeat revascularization. Actually, in my case, I use the IVERS for my case, but I didn't show the IVERS for the case because maybe the limited of time. So I didn't show, but actually this case we use IVERS. In my center, 2 years ago, we used the IVERS. IVERS penetration in my center is about 60%, 60%. For the case with the calcification is about 90%, and left-man PCI 100% IVERS. And recently, 1 year recently, we use IVERS for almost 90% case of PCI. On case, we try to do the IVERS. And because the high penetration in our center is because we re-sterilize the IVERS catheter from the Boston. I think it's very good for re-sterilize because we can use at least 2 times more when we re-sterilize. So that's the reason why we use a lot of IVERS for the PCI in our cath lab. So come back to the role of the IVERS or the intravascular imaging in the restenosis, instant restenosis. I think it's very important. Of course, the OCT is better choice, but IVERS and especially the IVERS, high definition IVERS, I think is a good choice because we can choose the strategy according to the intravascular imaging. For example, if we have the neo-atherosclerosis and the plaque is soft, so when we can do the PCI in this situation, is similar to the novel lesion. We can just use the NC balloon. I think it's enough for the patient. But if you can see the neo-intima hyperplasia, very thick hyperplasia, so the option is about, I think the best option is the scoring balloon or cutting balloon to cut the hyperplasia, because if you do the instant restenosis, if the thick hyperplasia, the balloon, the NC balloon cannot cut the hyperplasia, and the balloon tend to move down and move up to the lesion. So we need the scoring balloon or cutting balloon to cut it, and after that we use the NC balloon. I think and after that maybe the drug coated balloon or stenting. I think it depends on the cath lab. So the intravascular imaging, I think it's very important, not only to see the mechanism of the instant restenosis, but also guide us to use which strategy for the instant restenosis PCI correctly. So I think intravascular imaging very important, and also the intravascular imaging can show us is it optimal after we redo the PCI for the instant restenosis. So thank you for your question about the intravascular imaging.
Yes, thank you very much, Dr. Vũ Hoàng Vũ, for the answering all the questions from the faculty and panelists. And this time it is over a few minutes, I think around 3 minutes. So we gone through the on corners of the repeat reverse after PCI or cabbage. So now I would like to invite Professor Phạm Mạnh Hùng to give to wrap up the conference and this conference and the closing remark. Thank you very much. Professor Phạm Mạnh Hùng, please.
Thank you so much, Dr. Ngô Minh Hùng. So this run so fast. So dear colleagues, may I, on behalf of the trans person, to have some words. So we have had a very interesting session today, focused on repeat revascularization in collaboration with Vietnam Society of Cardiovascular Intervention and Thống Nhất Hospital, and of course the Sky colleagues from America. I highly appreciate the contribution, because I know that right now is midnight in America. We have just gone through amazing presentation with the full cases and interesting discussions, recent understanding in instant restenosis, along with improved innovative techniques, and opens a new chapter of repeat revascularization, such a kind of PC to more complex lesions and patients with encouraging results. With the introduction of the novel tools for the diagnosis and therapies, more patients with WHIM become eligible for percutaneous treatment. In addition, more effective and durable treatment should become available. I'd like actually thank you all presenters for taking time to deliver the lectures, and also the contribute to tremendous to this discussion. Of course, my co-chair, Professor Hồ Thượng Dũng and Professor Thanh Nguyễn, and all the panel members for their contribution. We hope to see you in person in October in Vietnam. It is a very special occasion of the 13th-year anniversary of the Vietnam National Heart Association and Vietnam National Congress of Cardiology this year. I would like to close today's session, and I wish you a safe and healthy, and thank you and goodbye, and see you very soon. Thank you so much.
Dạ, em cảm ơn thầy Hùng, em cảm ơn thầy Thạch, thầy Dũng, anh Hùng, Ngô Minh Hùng, bác sĩ Tân, bác sĩ
chào.
Bác sĩ Huy, anh Huy. Dạ, cảm ơn cả nhà. Dạ, chúc mọi người Chủ nhật vui vẻ. Cảm ơn thầy Thạch. Dạ, cảm ơn thầy.
Cảm ơn.
Cảm ơn Hùng, cảm ơn thầy Thạch, cảm ơn Dũng.
Cảm ơn anh thầy, cảm ơn mọi người. Xin chào mọi người.
Xin chào mọi người, cảm ơn mọi người.
Okay.
Thank you. See you.
Good night. Good night.
Good night. Good night to
Thank you. Bye-bye.
Thank you very much.
Thank you so much.
Chào thầy.
Dạ, cảm ơn thầy Dũng ạ. Dạ, em cảm ơn thầy rất nhiều ạ. Dạ.
Chào các bạn.
Dạ. Chào bạn Tân. Chào bạn Tân.
Chào các anh các thầy ạ.
Chào Tuân.